towards the shared goal of eliminating Hep C as a public health issue in England. We've got a WHO target of 2030. NHS England has said we'll try and do it by 2025, partly because of the excellent arrangements that we've got in place for things like the provision of medication. So there's no cap on the number of people that we can treat. We're treating as many people as we possibly can, all the time. I mentioned about close collaboration being the kind of key thing. Across a whole range of providers, and addiction providers are really important within that picture, and I'll come on to that very shortly. But really what we're trying to do together is to eliminate the virus. So what have we got in place? We're progressing with the existing elimination initiatives, and there are a lot of them. There are too many for me to go into. I will mention some of them as I move through my slides. But the other thing that we're trying to constantly do is innovate, work out where it is that we might find individuals who haven't been able to access testing, who haven't been able to get into treatment, and looking everywhere that we possibly can. We want to make sure that we don't leave anyone behind. So the things that help us to do that, 23 ODNs that we have commissioned across the country. Those are the adult treatment services that are responsible for overseeing the pathway in the local area. So we've got 23 of those fully engaged, actively patient finding. And what I'm working on is a 2-year funding allocation from the 1st of April 2022. So most years they've had a 1-year funding allocation and had to just try and work out, and we've had people leave because they're getting towards the end of their contract and so on. We know that we're around for the next 2 years because we've extended our pharmaceutical contracts for 2 years, for 22, 23 and 23, 24. If we know that we're going to be around and we know that we're going to be looking for people and treating people, it makes sense for us to give the ODNs a bit of security going forwards to say, yes, we need you for the next 2 years and this is the money that you're going to get. In terms of the pharmaceutical industry partners, we've got some really well-established initiatives tailored to at-risk patient groups. And the key thing is they're yielding results, and where we monitor those on a monthly basis between NHS England and the pharmaceutical industry partners to make sure that we're getting to where we need to be with those initiatives. And then the programme partners, probably too many to mention, and I'll kick myself afterwards for missing somebody out, but certainly addiction services, the Hep C Trust are involved at every level in pretty much every elimination initiative that we have, getting us that privileged access to people with Hep C, and getting us in there, encouraging and supporting individuals to engage with testing and treatment. But then also the whole wider field of UK Health Security Agency, NHS England's Cancer Programme, NHS England's Primary Care Directorate and Information Governance Team, a whole range of different organisations that we pull in to try and help us to deliver more and better. So where are we now? Well, over 60,000 individuals have been cured of Hep C, which is a massive achievement. That's since 2015. There are estimates about how many might be left. UKHSA think that might be around 80,000 left, but we're still doing further work to work out how many individuals are left for us to treat. But we've treated and cured over 60,000. Just interesting in terms of context, we've normally been treating about between 10 and 12,000 a year for the past few years. When we hit year one of COVID 2020-21, we dropped to 7,763 treatments. It could have been an awful lot worse than that. We delivered 60% of our usual capacity during that first year of COVID. A significant proportion of that was because of the street outreach work that was done with homeless populations and the people who were temporarily housed. That made a big difference to 2020 and 21 as a year. And this current year, where we're still dealing with the effects of COVID and still dealing with some restrictions. So up to the end of Q3 21-22, we've had 7,241 treatments, so still less than we were pre-COVID, but still progressing, still moving in the right direction. And hopefully by the end of Q4, we'll have exceeded what we did last year. So hopefully now you can see a slide with a graph that says the population's changing. So we kind of, this, in the first few years of the Hep C elimination programme, we knew that where there were a lot of people who were infected with Hep C, who we needed to get into treatment, and we got them into treatment. And we had a lot of people coming forwards and asking for testing, asking for treatment. I think we've mostly, not entirely, but we've mostly got through that cohort now of people who are very motivated and looking for treatment and asking for treatment. And the onus is falling much more on us to go out and find the patient rather than the patient finding the treatment. So over time with the programme, I think it's fair to expect that it will become more and more difficult for us to engage people. We'll work through the easier to find ones, or the easier to engage ones. We'll then work through the ones who take a bit more finding or a bit more persuading, and then in reality we're going to get to the stage where we might know who all of the people are who are still infected and haven't had treatment, but they might not want it. So over time it's going to become more and more difficult. So we know that the drugs work, and the question is, how do we get people to take them? So we're going to have to see that effort. You'll see with the orange line being effort. The effort is going to really have to ramp up for us to be able to keep finding those individuals who are willing to engage with us for testing and treatment. So just in terms of thinking about that, how we go about that, those early days of people who are very motivated and presenting themselves forward for treatment, or it was easy to find and easy to engage. Clinic settings were absolutely fine. People were quite willing to go to clinics. Now I think less so, and there's going to be there is already, I think, a bigger reliance on outreach, and we've seen that through the brilliant work that the community vans have been doing, and through the work that ODN clinic staff have been doing with in-reach clinics into drug services, into prisons and so on. We're going to actually have to go out to the patients an awful lot more than expecting them to come in. And then towards the end of the line, with the increasing effort, it's a bit of an unknown really, and that's why I've put question marks. It's what Graham Foster would refer to the God only knows group. It's difficult to work out how and when and where we're going to be able to engage with those individuals, and if we do engage with them, are they going to be willing to engage with testing and treatment? Possibly not. And what we have to accept, I think, is that there will always be some people who do not want treatment, and that's perfectly within their right to not want treatment. It might not be what we would want, and it might not be what we want for them, but actually if they don't want treatment, they don't have to have treatment. It's their basic fundamental human right to not accept treatment. There'll always also be some people who we cannot find. That doesn't mean we don't try, and doesn't mean we don't try hard, but there will be people that we can't find. But our aim still needs to be to treat all of the treatable people and then move to something that looks like business as usual or maintenance. So get to a point where we found and treated as many as we possibly can, and then we need to say, okay, elimination is not the name of the game anymore. What we have to do is embed a standard of testing and care within mainstream services that will pick people up as infections crop up. And I think in terms of that outreach and focusing on the achievable, as a minimum, we would want to see that every patient in addiction services and needle exchange is offered test and treat, ideally every 12 months. We want to see that every person in prison, every patient in prison is offered testing and treatment, and that every other kind of at-risk person who's registered somewhere in the system, so whether that's people who are on probation, homeless, migrants, those who've been exposed to infected blood or blood products, people who are HIV infected, are offered test and treatment. We need to make sure that we've done everything that we possibly can with that middle group to engage them and to draw them in. So I won't go into much detail on this because a number of you will know about it, but there are continuing elimination initiatives, and these are just some of the ones that they're critically important, but they're things that are carrying on. So we still have a very active program in prisons where they're trying to achieve micro-elimination and full population testing. Again, probation services where we're going in and population testing. Community vans, which a number of you will be aware of, a number of you will work on a regular basis. We've got 11 of them at the moment, more coming up, which I'll mention on my next slide. We've got a significant prevention work program working on low dead space syringes and other kind of prevention of infection and reinfection. The significant work that you're doing in relation to people who use drugs, recovering your services from COVID has been a key part of that, and getting people back to a process of testing the cohorts within drug services, but also now increased testing in needle and syringe programs, especially within community pharmacies. We've just funded a further 11 ODN projects to go in and do testing in needle and syringe programs within community pharmacies and agency-based needle exchange, and then some further targeted activity around how we reach homeless populations, asylum seekers, Gypsy Roma traveller populations, South Asian populations, and now adding into that Eastern European populations, where we're tailoring programs to try and make sure that we don't miss anybody. So newish elimination initiatives, and I've said newish because some of these we've been slogging away at for about 2 years to try and get them up and running, and they pretty much now are. We've got the emergency department pilots working in 7 ODNs across England. That covers 12 emergency departments. That work is going to be very closely linked in now to the national programme that is running for high risk areas for HIV testing in emergency departments, which will be the whole of London, Greater Manchester and Brighton. So the work that we're doing already on emergency departments is going to feed in and work alongside that national HIV programme. Non-specialist settings, we're piloting some work in both addiction services, where the addiction service is the treatment organisation with arm's length clinical support from the ODN, and a couple of primary care services where GPs are the lead clinician with arm's length support from the ODN. So we're trying to kind of democratise treatment availability across the system rather than just holding it within that kind of specialist ODN clinical setting, but maintaining the specialist support. Big programme of joint work with the cancer programme at NHS England over the next 18 months or so. So this is where I mentioned about the vans. They've been so impressed by the work that we've done with the community vans that they want some of the good stuff that we've got in terms of access to wider communities, those experiencing health inequalities, those who are unwilling to come into or unable to come into mainstream health services. So a further probably up to 10 vans joining the existing community vans with fibrous scans, potential for ultrasound scanning, but also with Hep C testing. So we're going to be pretty much doubling the fleet of vans and increasing the the ability of all of them to look for wider markers of liver cancer as well as look for Hep C. So we're really quite excited about that as a piece of work. Web-based testing will be out to tender by the end of this month, finally, after 2 years in the gestation. So there will be a web-based portal where individuals can go on if they don't want to go into a service, or they can be directed to web-based testing by targeted communications or by letters from their GP or wherever. To go on, get a home testing kit, and then be engaged directly into treatment if they've got a positive test result. And that'll probably be, not necessarily, but it'll probably be a capillary blood sample that people do, so that we can get PCR and genotype from the sample. Primary care, we're continuing to roll out the primary care GP PSI tool and some other work with EMIS, and then new targeted activity. So we have a sexual health pilot. We've got some antenatal screening that we're currently working on with the National Screening Committee, and we need to further look at treatment pathways in harm reduction services. So one of the key things that we need to do over the coming year is to be able to evidence elimination and improvement, because if we can't evidence it, we can never say that we've eliminated. So we've got some model-based work done that that UKHSA and other colleagues have been doing based on different models. But we're also running an incidence study with a 10,000 individuals cohort, so 10,000 people who inject drugs, and they will be tested within drug services at 0, 6 and 12 months, so that we can actually find out what the incidence of Hep C is between amongst people who have injected drugs or are injecting drugs. Similarly, we've got a 4,000 cohort reinfection service evaluation that we're doing with the ODNs, so they will get fed back on a monthly basis a list of people who they've treated on a certain time that we've randomly selected from the treatment cohort, and they will then be asked to be followed up with further tests up to a year ahead. So we've called it SVR 48, but it's kind of up to 12 months ahead. So that we'll be able to see what the rates of reinfection are amongst those who've been successfully treated. There's obviously the primary care study that we've commissioned the University of Bristol to undertake, 100,000 individuals in primary care with no obvious risk factors, so that we can see what the general incidence is within primary care settings. And we're doing some significant work around data sharing to ensure that clinical data is available across the piece to be able to facilitate and enable direct patient care. So if somebody comes into an ODN and that ODN doesn't know where the individual was previously treated or previously tested, they'll be able to go in and find all of that out without having to kind of start from scratch. So it will assist with that kind of patient care. That's the list of all of the things that we're kind of doing at the moment. I'm not going to go through it because it would take me hours, but different staff members in my team are allocated different bits of that work. If there are any that you particularly want to know about, then obviously you can contact me or Hep C Inquiries, and we'll put you onto the member of the team who's leading on that. So for instance, Georgia Threadgold leads on the justice system work, Speciosa Nabatico leads on the primary care work, so that there are ways that we can kind of link you into any of those that you're particularly interested in. So we've already shown some notable achievements, and by we, I mean you as much as anyone else. Over 60,000 treatments with around a 98% cure. We're probably at about 65,000 treatments now. We've reduced HCV mortality by 20%. That was by 2018, when the target was 10% by 2020. So we've more than met that. In terms of the current WHO targets, the target rate is two cases per 100,000 in terms of mortality. We're currently on 0.53 per 100,000. So we've done some really good work on HCV mortality since the start of the programme. And liver transplants similarly have halved, and these are specifically related to HCV in the last 10 years. So we need to keep being able to measure and evidence that the programme's making a difference, and it is. And it's because of people like you out there pushing testing, making sure it's happening, making sure that patients feel comfortable to come forward and test and accept treatment and be cared for throughout that treatment. So I just want to say a big thank you to all of you who've been involved in that work, because we wouldn't have achieved any of these things without people like you actually there doing the testing and treatment. And that's just my contact details if anybody wants to get hold of me.
That's brilliant. Thank you, Mark. It's really comprehensive. I think it's quite clear that there's a significant level of focus and resource going into this at the moment, and it's really good to see all of the sort of planned work as well, the breadth of it. I'm just going to check the chat and just see if we've got any questions at the moment. We've got one question. Will we be sent the PowerPoint slides? I don't know, Mark, are you able to send it on to us? Or
I'm happy for you to share my slides.
Yeah, absolutely. And one from Deborah Moores, who is one of our Hep C elimination warriors. She's saying, how privileged are we to be a part of this? Not a question, really a statement, but yeah, absolutely. I think we all feel that way. If you do have any questions, please post them in the chat, and I'll just check with the other presenters in case they have a question for Mark at all. No, just while we're waiting. No, you got away easy, Mark. That's great.
Well, I'm staying around, so if you think of something.
Absolutely.
I've got my only question, Mark, is obviously I have a vested interest in the VAN projects. It'd be really good to maybe get all the VAN projects together to actually share the learning ahead of the liver screening vans coming on board. Because I'd imagine across the network, we've all got phenomenal learnings and things have gone well.
Yeah, we did it recently with the emergency department leads and brought them all together to talk about what they'd achieved and where they'd had difficulties and how they'd overcome them. So we can certainly do that with all of the van leads as well. I'll ask Taryn in my team to pull that together.
Thank you.
Fantastic. And Claire Edmondson, you've got a question for Mark.
Yeah, it was just your final slide with all the projects that you're working on looks great. But the thing that I thought looked quite interesting was a project into image and performance enhancing drugs. So that's something we used to in our team. We used to run a surveillance of that population, and it's really quite hard to engage with them. So I just wondered what work you were doing there, if you knew any more about it, really.
Yeah, we've got a few of the ODNs are doing little bits of work into a lot of the time with pharmacy needle exchanges or other needle exchanges where individuals are going and getting their needles for performance and image enhancing drugs. One of the pieces of communications work that we're working on is related to the testing portal, the online testing portal, so that we're hoping that we'll be able to put QR codes up in gyms so that people will, if they see it, we can put something, ever injected, steroids, ever injected, anything for image enhancement, and people can just literally scan the QR code, don't have to engage with any service, and can literally just get their test sent discreetly through the post by going onto an NHS website requesting a test. So that's one of the cohorts that we're planning to kind of specifically market the web testing portal at.
That sounds great.
Fantastic. So yeah, please do post in the chat if you have any more questions. What we'll do is we will move on just because of time. So next up we have Katie Elsden. So Katie is a harm reduction nurse from South London and Maudsley Drug and Alcohol Services. Her role is to reduce drug-related harms and develop public health initiatives, which includes leading on BBV work. She's a really strong advocate for empowering service users and promoting health and well-being. So it's fantastic that we have her on side with the Hep C elimination agenda. So Katie is going to provide us with a bit of a recap on Hep C testing results and treatment, but also a little bit about her experience in reducing some of those barriers to the testing and the treatment. So again, please do post questions in the chat. We'll have 5 minutes after our presentation. So Katie, over to you.
Thank you, Jan. Let me just try and share this screen and bear with me because this is the part that I've been dreading the most. Can everyone see my slides there?
We can.
Yeah, fabulous. Thank you. So my name is Katie. Hello, I am the harm reduction nurse here at Wandsworth and Richmond Community Drug and Alcohol Service. We're part of the South London and Maudsley NHS Trust, and I'm here today to talk to you guys a little bit more about Hep C and bloodborne virus testing from the understanding and working of a typical drug service. I totally appreciate there's a wealth of knowledge in the room, so apologies if this is a recap for anyone. But like you guys have been informed, there's a space for questions at the end of this, and if there's any technical difficulties throughout, just let me know, because that is certainly not my area of expertise, so please bear with me. Right. Thank you. So speaking on behalf of our drug service, we, like most, employ and aim to work within an environment, that recognises harms associated to substance use and aims to minimise that. So if you define the term harm reduction, I guess you could argue that everything we do as a drug and alcohol service and as drug and alcohol workers aims to minimise harm. Just by being an open service and an open space for service users to come to could be an example of harm reduction. However, thinking more broadly, it's also a movement for social justice built on the belief and respect for the rights of people who use drugs. And I think that's really important in the work that we do for hepatitis C also. I think it's a really realistic way of working, especially with clients who are using drugs and alcohol, and it's trying to work with them where they're at rather than where we as professionals, why they themselves, where society thinks they should be. So hopefully with taking this stance, not only are we aiming to reduce the harms associated to drug use, but also empower service users to make more protective choices in regards to their health and well-being. And again, the bloodborne virus work that we do and the hepatitis C screening that we do comes into this massively. So just a bit of background on harm reduction. So as I said earlier, my role here is the harm reduction nurse. I've spent the majority of my nursing career working within inpatient psychiatric care and community addictions. This, however, is my first role where I've had more autonomy and creativity and the ability to spend a more conscious time on health promotion, like Jan said earlier, within a drug and alcohol service, which I've found to be really important and beneficial. I've tried to summarise my post here for reference or to bore you all. However, one of my key responsibilities here, and going back to the theme today, is oversight of the bloodborne virus programme here within our drug and alcohol service, in particular our hepatitis C pathway. So looking at what we do in regards to bloodborne viruses here at Richmond and Wandsworth Drug and Alcohol Service, we're a relatively big drug and alcohol service. We are located over 2 London boroughs, Richmond and Wandsworth. All of our clients that are triaged and accepted into treatment should be routinely screened both for full blood works and BBVs, bloodborne viruses. That's often included in our full blood work request. This is often a recommendation we give to onward referrals, so people who aren't accepted into treatment for whatever reason, and for people who are discharged to our service as well, just so they've got an understanding that this is important out with the drug service and the work that we do here also. So we currently operate an opt-out scheme, as I'm sure many of you guys do in your drug service for bloods, with all clients ideally having been taken upon triage. So when they first come into the service, they'll be asked to provide full bloods with us, which is a really good opportunity for us not only to see what their bloodborne virus status is, however, also to get their full blood works as well for their physical sort of oversight. So then, dependent on their risk exposure, we recommend that their bloods are taken at least annually following that, which was a topic in the previous presentation. However, if they're more, if their risk exposure is higher, then we would recommend that the frequency of their screening of their blood test is done more regular. In some circumstances, this is done monthly. When we think about people who are particularly high risk, for example, injecting drug users, not exclusively. However, we would aim to have their bloods and their bloodborne virus state taken and screened more frequently. And again, that's dependent on the client's wish and the sort of team discussion and reflection on that as well. Looking at our typical BBV screen, I'll refer to bloodborne viruses as BBV throughout this just to avoid confusion. But yeah, as mentioned, we largely use full venous bloods at our service or capillary blood tests, which I believe is going to be spoken about throughout this morning. And we typically test for the hepatitis C antibody, the hepatitis C PCR. In some cases, you will get a genotype and a viral load from your blood results. We also screen for the hepatitis B surface antigen, HIV, and hepatitis A total. And again, this is quite a typical BBV screen. We also offer sort of immunization against hepatitis B and hepatitis A as well, which is really important for all of our clients. So going back to risk exposure, I've included some common contributors to BBV exposure. This is not an exclusive list. However, I think this is pretty relevant to our drug and alcohol service. And looking at some of these suggestions, I've certainly come across examples of this in all of our current work. So looking at injecting drug use, and apologies, that's my doorbell going. So looking at injecting drug use, sharing paraphernalia, reusing of equipment, and any ambivalence and chaotic engagement, erratic engagement, we see time and time again as huge contributors to BBV exposure and virus transmission and bacterial transmission of infection. So looking at hepatitis C from a drug worker perspective, I feel that there's some key things to know. Hepatitis C can be cured either by the body or by treatment. However, I think it's really important for people to be informed that they can be reinfected by hepatitis C. So even if they've had treatment for hepatitis C, they're not immune to hepatitis C. They can run the risk of being reinfected by this disease. So I think that's always really important and a really important point to share with people who are going through treatment or certainly considering treatment for hepatitis C. It can be caused by some of the examples, some of the exposure risks that we looked at earlier. It's a bloodborne virus, so it's transmitted by blood predominantly, and it predominantly affects the liver and how the liver functions by inflammation largely. However, it can cause much more significant liver damage and disease if left untreated. Hepatitis C also may present in a number of different ways. So we often see clients who are found to be positive complaining of symptoms like lethargy, of muscle aches, depression, changes to their mood, which may be overlooked by us as professionals and by them to be a consequence of something else that's going on with their physical health and mental health. And often this could be signs and symptoms of hepatitis C, and often these signs and symptoms have been exacerbated by the hepatitis C disease itself. I think it's especially important when we think about the clients that we work with. So thinking about things like the effects of certain drugs, the effects of alcohol on the body, as well as thinking about some of those key withdrawal symptoms that clients go through and experience on a day-to-day basis in the drug service. So another key point for someone working in a service like mine, thinking about hepatitis C, I think it's really important to know that hepatitis C itself, the disease is categorized in 2 stages. So there's the acute stage, which is the first 6 months where most people can clear the virus spontaneously by themselves. I believe it's about 15 to 30% of people can clear hepatitis C without treatment. Some people may never know that they've had contact or have ever had this disease itself. And the second stage, known as the chronic stage, which often requires intervention. I think if you think about the sort of typical client in a drug and alcohol service, often will be the case that they are going to require intervention to treat and to clear their hepatitis C and the symptoms of that. However, that's not always the case. Again, thinking about my service similar to yours, most likely, I think it's important to note that clients are often really quite reluctant to share their risk exposure for a number of reasons. I think the UAM survey is a really good indicator of what's going on and why it's so important to do this if you have the opportunity, because it shows us even now with all the sort of resources that we have, needle exchanges, etc., sort of all the screening tools that we have to support people, that there is still most definitely people reusing equipment, people sharing equipment, and people not accessing services like needle exchange or drug and alcohol service. So I think it's really important for key workers to try their utmost to create a sort of non-judgmental, transparent environment so clients feel able to share things like their risk exposure and be honest about that and be open about that so we can support them as best we can. I've also found in my experience that hepatitis C can receive quite a lot of bad press from clients. I think people refer to hepatitis C treatment as for what it used to be. Either they've heard lots of myths and legends about interferon treatment that has completely put them off even being screened for hepatitis C, especially if they've been around a bit longer, if they've been using a bit longer, but also very much so if there may be a more younger, more naive user. They may have been around people who were involved in the interferon or may have had interferon, had a bad experience for whatever reason, and it's put them off even seeking screening or treatment, or considering that certainly is something that we hear quite often. Also, again, working in a typical drug and alcohol service, you may find that people are incredibly reluctant to have their bloods taken, even by capillary blood tests. We do see a lot of people very reluctant to have their bloods taken. We're going to get into some other forms of testing that you could consider if this was something that you were coming across. The treatment, in my experience, has been incredibly straightforward with minimal side effects, even for particularly complex clients who we've worked with. I think the most important thing, certainly from my perspective, is knowing the details of your ODN, your Hep C peers, any of your resources, and really working on that rapport and maintaining good rapport and maintaining those relationships. I've been really lucky with mine. They've been a lifeline for me, and I really, it's really supported our service most definitely in treating our clients. So looking at the types of tests, again, not an exclusive list. However, these are the types of tests that we've come across here. We have the dry blood spot test, which we only tend to use for our UAM survey, which I think we're going to talk about a bit later here. Again, I can't stress the importance of doing the UAM survey. Obviously, it's anonymized results. However, we get the results back and it gives us a really clear synopsis of what's going on for the typical service user, for anybody that's injecting currently or anyone that's ever injected before. And it's been really helpful in thinking about ways how we can promote and improve our screening program here at RWCDAS. We've got the point of care test. This determines the HCV antibody. So that often is the case, and this is quite a very quick test which will tell someone if they're positive for the antibody. However, often is the case that you'll require an additional blood test to determine whether or not the hepatitis C is active. We've got the capillary blood test, which is what we predominantly use here at our service. This is often referred to as the finger prick blood test. Clients often get quite alarmed when you present the test tube. You never have to fill the full test tube. So I always think that's the most important point to share with them. This tends to work for the majority of our clients. I'd say a good percentage of our clients find it really difficult to get a vein, and they're very reluctant to have venous bloods. So the capillary blood test is really a lifesaver, and it's been a game changer for our service. And again, like I said earlier, this test, if it's done correctly, will test for the hepatitis C antibody and PCR, and sometimes the viral load and the genotype if you have a sufficient sample. So it's really, really helpful. And it's just a finger prick blood test. We offer sexual health screens here, most of which will contain a BBV screen, a capillary blood test, and obviously we do the venous bloods as well. This is preferable if possible, because obviously you'll get the liver function as well as everything else. So it's always really good practice to have that if you can. And of course, the ODNs have been really supportive with us getting our venous bloods on some of the more trickier occasions. So looking at hepatitis C testing, there's 2 tests that need to be done to determine if somebody's got active hepatitis C. As I said earlier, the first test is usually done as the antibody test. This will look at if you've ever been exposed to hepatitis C. And even after clearance, the individual will remain positive for the antibody, which is always such an important thing to inform the clients. I've seen this time and time again where people have cleared the virus. However, obviously they'll remain positive for the antibody, and you know this has been flagged in bloods years down the line, and it's caused a lot of stress. So it's always really important to let people know that it's 2 tests that determine if the virus is active. The second test, which is the one that we're particularly concerned about, is the PCR test. This establishes whether or not the virus is active at that time. And again, it's really important just to clarify with any client that you're doing, especially if you're doing things like dry blood spots or point of care tests, that you will need these 2 tests to establish whether or not the person's currently active. The 2 tests can be obtained from a single capillary blood test if it's being done correctly, or the full bloods, as I said earlier. And it's often reported as hepatitis C antibody positive, or PCR detectable or undetectable. The positive results are often given in terms of the amount of a virus present in the blood at any time. This is known as the viral load. Often the drug service will get access to these results. This will determine how contagious the client is at any point, or how progressed their virus is. Anyone PCR positive will require a specialist onward referral. And I would even, for people who don't even want to consider treatment, I would always offer a space with the ODN for a discussion. There's no pressure put on clients to have treatment. I've certainly can vouch for that. I've had that, never seen that in my experience. But the ODN will give a different sort of element and use their expertise to talk clients through their options. If somebody is keen to have treatment, they will complete an initial assessment. Further bloods and scans will be taken, a fibre scan of their liver, to determine the state of their liver and to determine what their treatment options will be. Again, like I said earlier, I've found it really helpful to have a constant live sort of dialogue between myself and the ODN, as well as the Hep C peers, Hep C later, all of my resources. But it's just a good space to just bounce things off each other. And if there's common clients that are known to both the ODN and our service, it's thinking how we can work collaboratively to sort of approach them, particularly with some of the harder to risk clients that we've certainly seen an influx of throughout COVID. So I was asked to think about how we deliver positive results. I appreciate this slide's quite text heavy again, but again, I wanted it to be a bit of a reference tool for people to go back to. And I just wanted to run you guys through some of my immediate thoughts and suggestions. So upon taking the test, I tend to explain to the client the rationale of why we're doing it, their risk exposure, and what happens in the event of a positive result. So sort of to brief them and to sort of reassure them what will be available to them and how successful treatment is in the event of a positive result, to hopefully ease any of those anxieties. I'd ask them if they were aware of any risk exposure personal to them, and ask that, try and get as much information about that. I would explain and introduce the role of the ODN at the point of testing. Often is the case that they're able to be with me at the point of testing, which makes it incredibly beneficial for the client. And upon receiving positive results, I'd always counter check them with my colleagues just to ensure that it's an antibody positive and a PCR positive, to avoid any mistakes or confusion with those results. It's always good to cross-reference that with a colleague. And I would also consider discussing and cross-referencing with the ODN in the first instance as well. And if someone was PCR positive, I would prefer to deliver the news face-to-face if possible. I appreciate that's been a little bit more difficult throughout COVID. And again, in that delivery, regardless, you'd want to be calm and reassuring without being forceful. We do have a number of clients who've chosen not to seek treatment, and understanding that that's okay. I'd want to provide an additional appointment, even if they're against treatment, with the ODN to consider their options, and really explore at the point of given the results what their concerns are and if they've got any questions. You've also got to be prepared to give a typical treatment overview, and know a little bit about the hepatitis treatment journey and the medications, but be completely honest if there's something that you don't know. Just be aware of how you're going to support them and how you're going to get those answers. And just throughout the whole treatment journey, be proactive and prompt, and just to give reassurance and install confidence and hope in their sort of expectations and their experience. I didn't want to spend too long on treatment, as I'm not part of the ODN, I'm not a specialist. However, I've included on this slide two of the more commonly selected medications and well-tolerated medicines that I've seen used in our setting, sometimes with the addition of ribavirin. However, Epclusa and Harvoni both have much more complicated names that I'm going to save my ego from pronouncing. But generally, these regimes are one pill a day with minimum side effects. Sometimes headaches, a bit of lethargy, but I've not seen anything acute in my experience. And this is working often with a lot of complex clients with cirrhosis. So it's really encouraging to see that. My advice as a drugs worker would be to shadow the ODN, explore the treatments, ask questions, and ask clients always about their experience, both before, during, and after. It's important to note that these medications have an average success rate of 97%, which is always really encouraging and nice to share with the clients as well. So to conclude my part of this presentation, COVID's hit us really hard here. We are remote working a lot. Our footfall has reduced a lot, and that's really significantly impacted our hepatitis C screening and our treatment pathway. So I've made a quick list of sort of current and hopeful future developments to improve our screening pathway. Just for some ideas, obviously the ongoing maintenance of our relationships with all of our Hep C resources, and thinking about how we can develop our outreach work. We want to sort of run a sort of regime here, thinking about client and staff incentives just to gather a bit of momentum with our screening, but also keeping the sort of ethos of hepatitis C screening, bloodborne virus screening central in all the work that we do, thinking about training, staff education, and empowering them. People have got lots on their plate at the moment. Demand is really high, as I'm sure a lot of you can relate to. So really trying to keep our sort of hepatitis C schemes and initiative alive throughout. And again, this is where I've really relied on the support of my ODN, my peers, and the Hep C later staff. So yeah, that's just some ideas for our service development. I've included some. We are constantly putting up posters. I can't claim any of the credit for these. These are kindly done by my very artistic colleague George. We would be in a very different position if I was designing the posters. However, yeah, just trying to keep hepatitis visible, keep it in our waiting areas, in our clinic room, in our key working rooms. You know, sending relative information to clients' home address if they're okay with that, and especially if we get more incentives to do bloodborne virus screening, we will definitely be promoting this throughout our service. Again, we like a freebie here at our service, so if we get anything, we try and promote that as much as we can. I had an audio clip that I wanted to share with you guys, which isn't going to be possible today, but I've got some written feedback from a couple of our clients who have recently completed hepatitis C treatment. I just wanted to read through them with you quickly. So one of the questions was, what would you say to someone who might be worried about starting treatment? And the answer was, just go for it, because it will make their health a lot better in the long run. And then another question was, how was treatment for you? And the answer was, it was fine, no problems, 1 pill a day with no side effects. So again, that's not a bit of an encouragement. I don't know what it is. And again, some references that might be of use to you guys. And that is me. Thank you very much for your time. I'm much appreciated, and your patience.
Thank you very much, Katie. I'm just going to have a look in the chat again and see if we've got any questions. I don't think we've got any come through, but please do post them throughout the webinar. We'll get to them, and if we don't get to them during the webinar, we'll get to them afterwards as well. And yes, some people coming, saying fantastic speech. So that's great, Katie. Thank you very much. It's really good, I think, to have your perspective on some of the stuff that you're doing, and I think that hopefully we can tap into that in the breakout rooms later when we have the chance to network as well. Has anybody else got any questions from the panel at all? If not, it's no problem. No, okay, no, that's great. So in that case, then I will introduce our next presenter. So our next presenter is Sophie Lewis, who's a field application specialist from Cefiad. She's going to talk to us about the very exciting GeneXpert Cefiad machines and tell us a bit about what they do and how they work. Please take it away, Sophie. You're just muted at the moment.
I was just about saying thank you, Deanne, and I see a lot of familiar faces, so it's a pleasure to join you all. I'm just going to share my slides. Do tell me that you can see them.
Yep.
Yeah, okay. I'll be really quick because I know Hayley is going to be presenting after me. So as mentioned by Deanne, I'm a field application specialist. I cover the southwest of the UK, so I've met a few people in the south based in as part of your program. And Cefiad manufactures the GeneXpert system and the Expert HCV viral load fingerstick test, which I'm sure a lot of you are already familiar with. Okay. So currently there is a need for a molecular test at point of care that targets Expert HCV. Because currently the centralized methods of testing have indicated that up to 46% of patients never actually receive confirmatory RNA testing. And furthermore, these centralized methods of testing can involve several patient visits, which can be up to 5, which is, for our clientele or patients, they can be a bit difficult to engage, is not ideal and it's not suitable. So let's take the test to the patient. So we take the test and we take them to decentralized services. So some of the services we cover include drug and alcohol clinics, mobile services, prisons, sexual health, community health centers, etc. And to promote the test, treat, and confirm cure point of care testing model. Okay, so that being said, Cefiad's GeneXpert technology is like no other. It's designed to deliver accurate results, fast, and it's very easy to use. Now, it would be nice to hear for you all that the technology that you're using is the same technology that is used in our centralized larger platforms. So for example, on the far right, we have the Infinity, which is a much larger form of the platform, which is automated. We find them in large private and public healthcare labs. We have another larger system, which is the GeneXpert 1616, but more familiar to you is the GeneXpert 44, some of which you've named very, very fondly as Cindy and and what have you, so that always makes me smile. And our motto here at Cepheid is to deliver a better way to realize the benefits of molecular diagnostics. Okay, so Cepheid supplies this expert HCV fingerstick test, which is a new solution for hepatitis C RNA detection. So as I said, it's very easy to use. How do we use it? You simply collect about 100 microliters of capillary blood in a mini-vet from the patient's finger. You load it directly onto the expert cartridges, which can be stored at room temperature, and then you run it on the GeneXpert 44 instrument, as you can see, and you get your results in less than or equivalent to 60 minutes. Now, with this assay test, there is an alternative use of 100 microliters of venous whole blood, but that will be with the use of precision pipettes, and that's more geared towards centralized lab testing. Okay, so with the help of the GeneXpert and the Expert HCV fingerstick test, we've helped to simplify this diagnostic pathway. Okay, so how do we do that? Because our test will target HCV RNA. HCV RNA is a much more targeting HCV RNA is a much more sensitive method of detection than an anti-HCV antibody test. So why is that? Because the HCV RNA is one of the first indicators of infection, and it tends to appear much earlier post-exposure of the patient or the client, rather than the anti-HCV antibodies, both in acute infection, as you can see on the left-hand side, and also during chronic infection. So what is the clinical impact? The clinical impact is that you can detect HCV RNA in as early as 1 to 12 weeks post-infection, and as such, it's indicative of a quick method or quick way to treat these positive cases, and also you can follow through of those people that have been treated. Okay, so as a quick summary, what is our value proposition? What's the benefit of the HCV fingerstick test and the use of the GeneXpert 44 system, which is nice and transportable, as some of you already know? It's the quality. So you're getting a lab quality test for RNA detection by PCR at point of care, so next to your patient. In terms of economic value, it's flexible, and we can support cost-effective algorithm based on the setting. So in settings where prevalence tends to be high, we will support that. Clinical value, like I said, we promote this test-treat model of care, and more patients on treatment can have improved outcomes. And finally, the operational value. So for those of you who are actually performing this test, it's a simplified workflow. It works in any setting. So as you can see with the mobile GeneXpert 44, and you can take the test to patients, especially in outreach settings. So with that said, that brings me to the end of my presentation. And I just wanted to say thank you, and I'll hand over to Hayley, or if there's any questions.
Thank you, Sophie. For anybody who's got any technical questions for Sophie, please do put them in the chat. I'll introduce Hayley Ward now. So Hayley Ward is the point of care testing manager at MSD UK Limited. Hayley's going to tell us a little bit about the GeneXpert CareFiab machines and how they've been used to support Hep C elimination. Hopefully that'll give it some context as well for those of you that don't know about CareFiab machines. So over to you, Hayley.
Thanks, Deanne. Can you see my slides? Are they showing? Wonderful. Thank you, Sophie, as well, for being a bit of a double act today. I appreciate that. And thank you, Hep C Later, for asking us to speak today. So good afternoon, everyone. I'm Hayley Ward. I work for MSD, and I project manage our point of care testing elimination initiative as part of MSD's overall elimination programme. Sophie's just done a great job of explaining what a GeneXpert is and a bit about its functionality, but I just wanted to share a little bit more about the MSD project and how the MSD funded GeneXperts are being used. So, can you see that second slide now?
Yep.
Yeah, great. Okay, so as you can see on the left-hand side of the slide, there are 20 funded MSD gene experts in circulation, and that's across 14 ODNs, as some ODNs do have 2 machines. Initially, these were allocated from the NHSC selection process that was rolled out at the very beginning of the tender. I had a 9-month lead-in time to set up and deploy the initiative, and go live for this particular initiative was January 2020. So originally, the plans for this initiative was for it to be solely across the prison estate, but sadly, due to COVID, we did have to evolve the project. And actually now we only have 3 prisons delivering reception testing, but very soon to be 4. And 16 of the MSD funded gene experts are being used in the community. Now, there's a wonderful blend of community projects. So they're being used to test patients and clients in drug and alcohol services, on outreach vans and buses, at homeless hostels and services. They're supporting street engagement testing events. We have a number of the fantastic Hep C Trust peers delivering testing. So shout out to Philippe Bonnet, Ollie Riley and Mark Burns. And similarly, Hep C later have 2 MSD funded gene experts doing amazing, amazing things. So thank you to Louise Hansford, Alan Howard and all the team for making this work so well. And finally, we have had 1 gene expert in a GP practice delivering testing to support one of MSD's other elimination initiatives, which is the patient search tool. We know that the gene experts add huge value in prison hits, and we'll certainly be supporting more of these moving forward as and when they can take place due to the current impact of COVID. So there is an impact on staff resource at the moment across the prison estate. So a little bit about process and the asks from MSD over on the right hand side of the slide. MSD do fund the gene expert lease, the cartridges and the mini vets. There is some due diligence that we require teams to complete, and this essentially consists of a CEFID checklist to ensure that the teams have thought about all the other things that need to be in place before starting the testing project, as well as a site survey, and this is just to make sure the location is suitable, but also that there are 2 main sockets, because you need 1 for the laptop and 1 for the gene expert. There is a technical training session that will be delivered by CEFID, which is about 2 to 3 hours and usually involves 2 to 4 super users who are trained to be competent and confident enough to be able to train other users. The ongoing technical support is provided by CEFID. Contact numbers are provided. There's 24/7 on-call support, and CEFID do also commit to fixing any faults within 48 hours. I do ask that testing teams provide numbers with me on a monthly basis, and that's mainly to be able to keep track of cartridges from a supply and demand issue, but also as MSD do have a reporting line up to NHSE, just to be able to demonstrate the effectiveness of all our elimination initiatives. And it's really, really important that I'm able to monitor these placements to ensure that they are adding value. Now, the gene experts can be relocated, so either within or outside of the ODN, and this is really based on need and there being robust plans in place. And any relocations will be done with plenty of lead time, just to make sure there are other forms of point of care testing available once that gene expert has been removed. Finally, I'm always keen to look for synergies, so either that's synergies within our own MSD portfolio or otherwise, and to share best practice and learning where this is appropriate. So really pleased to say that for years 4 and 5 of the tender, we'll be adding an additional 5 machines to the MSD pool, taking us to 25. And we know from feedback from a lot of the users that where they work well, they work beautifully and they can be a real game changer. So with that, thank you to those of you who have an MSD funded gene expert, and I know you work really hard to ensure that its use is maximised and that we find and treat as many people as possible. Thank you for listening, and I'll hand back to you, Deanne, to see if there's any questions that have popped up.
Hi, thank you very much, Hayley. So we do actually have a question in the chat, but I believe this is aimed at Sophie if she's still around, which is, what's the correlation between raised ALT and Hep C viral load? Sophie, are you available to answer the question?
Yes, I'm still here. I'm going to be honest, I'm not sure off the top of my head. It is a very, very specific question. I have a feeling ALT is linked to an enzyme produced by the liver. But in terms of its correlation with the viral load of the hepatitis C virus, I'm not fully sure. I can pass it on to our med sci and they can dive deeper and I can come back with an answer.
That's great. Thank you, Sophie. Sorry to put you on the spot. Does anybody else have any questions at all for Sophie or for Hayley? I haven't seen anything come through to the chat. So what I'm going to do is I'm going to bring in Louise Hansford next, who is also a Hep C elimination coordinator for Hep C Later and my counterpart in the South. For any of you who know Louise, you'll know that she's a force of nature, which is probably an understatement, in the elimination of hepatitis C. She's done incredible things in her many years before Hep C elimination initiative started, setting up award-winning projects like the HANTS P2P project. She's got an unwavering tenacity and constant drive to empower service users and get them treated. And she's going to tell us a little bit more about how to access the Gene Expert Kefiad machines through Hep C Later if you're part of the NHS Addiction Providers Alliance. I'm sure she'll talk about that. Louise.
Thanks, Deanne. Gosh, that's an introduction and a half, isn't it? Hi, everyone. For those of you that don't know me, I'm Louise. I'm Deanne's counterpart in the South and Cumbria. So I'm just going to talk to us a little bit about our Hep C Later funded machines. And I'm just going to try and get... So can you see my slides?
Yeah.
Oh, meet the family. So this is, sorry, I'm just going to get rid of the cat. So these are Cindy and Cyril, and the stickers are provided by Mary Fay, who's Debbie Moore's, one of Deanne and I's colleagues in Humankinds. Debbie's daughter has made all the Kefiad family stickers, and so and although it's a bit of fun and we've named them, there is a more serious use of the naming of the machines, because when you've got multiple machines across the network, it's really good to be able to work out which machine did what. So yeah, this is Cindy, who you know, for those of you that have known me, I've been to conferences all around the world, and there was a dummy machine in the Portugal conference, and we were playing around with Mary Parker and I, a nurse from One Recovery Bucks, and I were kind of telling Jane, one of the Cepheid promoters, I guess, or staff, that we were gonna pinch this, and it has been one of my missions since I've worked in Hep C to get one of these machines, and I've got to say they really haven't let us down. So the extended family. So here's Debbie with Celia up in the north, and Clarice, which is the Wessex ODM machine. We've got Costas in Leicester, Charlie, Shaney, which is Philippe Bonnet's. So we've really kind of reached out. And again, the great thing about Hep C Later is our ability to share learnings and experiences and things that have gone well, things that haven't gone so well across the network. So we've really enhanced that. So what we Cyril goes across the Addictions Provider Alliance and is available for people and organisation services to use. He's been to One Recovery Bucks, he's been to Bath, Bristol, the Isle of Wight. He's currently in Hounslow, and the hepatology nurse and Craig from the Hep C Trust regularly use him in the clinics to monitor treatment compliance, SVRs and new diagnoses. So what you get from the Hep C Later offer is the full training. Sophie and her colleague Rachel are absolutely phenomenal at answering questions, at supporting us, you know, as are the MSD team. Deanne and I have developed standard operating procedures just to really give people a head start on how they can be used. So to get the most out of them, it's really about doing the data informed piece of work. So on the drug treatment monitoring system, we really want to change those people that are showing us positive PCR to negative cleared by treatment if they've had treatment. So by utilising the Cepheids, you get a result within an hour. There's nothing like being able to tell somebody on the same day, you know, gone are the days where you had to wait 2 or 3 weeks and then the lab would tell you they'd lost the bloods or it was insufficient sample, you know, so you've got to put people through the trauma of having needles poked in them. You know, we've really worked with the ODNs to develop pathways. So across our network, we've got hepatology nurses that will treat from a Cepheid result, which is fantastic. And our Wessex Clinical Van, which is an NHSE initiative, we're very much working to do same day test and treat. We partner and we regularly communicate with the Combi Clinic in Australia, who are part of the INSU network. Again, you know, we share all the learning of how they do it worldwide. So one of the beauties of this machine is we identify reinfections quickly, and Sean and Claire were out in Dorset on Monday. There was a guy that we tested post-treatment and gave him his SPR in November. In January, he's been reinfected. So again, you know, this we've been able to intercept that really quickly and get him back on the treatment pathway. It excels at doing high intensity test and treat events and combining interventions. So one of the things that we've done recently, you heard Katie talk about capillary bloods earlier. And the benefit of capillary bloods is for those ODNs that still want a genotype, it allows you to do that. So we recently supported Nottingham in their NHSE award capillary bloods testing pilot. So we quadruple sampled people for so we did verification validation on venous bloods, capillary bloods. We also did everybody for the Unlinked Anonymous survey that our colleague Claire's going to talk to you about in a minute. And we also sampled everybody with the Cepheid machines. So again, we've got 30 samples that we can, for anybody that's worried about validation, verification, we can give you that evidence. We when you're proficient in doing the samples, well, even when you're not proficient, you know, by using the Cepheid alongside the UAM survey, you know, we've done probably 250 tests in the last year, and we've sampled people for the UAM survey at the same time, which has the added bonus that you get a wealth of information about them. You know, you can really tailor your interventions. The report gets used for additional funding and resources, but you're also able to give them the £4 incentive, £5 if they live in London. So yeah, so the outcomes so far, you know, across our network, we've done 552 tests. We've picked up 145 people with RNA detected, 44 of those who have needed retreating either due to compliance or reinfection, 69 are first diagnoses, and of those there were 18 people that at least that were not engaged with any drug services. So the only way we're going to reach elimination is by engaging with those people that sit outside of drug services for whatever reason. You know, they may not be able to stick to scripts, they may not be able to, you know, stick to drug treatment regimes. So 32 people re-tested, re-engaged, and some of those have been long term. You know, Deanne mentioned earlier, you know, I've been in Hep C now for 10 years. You know, there's people that Alan and Sean have been able to engage with Cindy that I have chased around Hampshire and Dorset for 10 years, you know, and the intravenous blood has been such a barrier. You know, this is honestly, these machines have transformed the landscape. 94 sustained viral responses and 43 confirmed as spontaneously cleared. And again, that's given us the ability to really provide epidemiological data, you know, to really get a wealth of information. So the case study, I just want to talk a little bit about one of our case studies that was in the Dorset HIT. So the high intensity test and treat. Now Fred came along, he was begging. Our Find a Friend team went out and did some assertive engagement. They brought Fred, that's not his real name, back to the van, and he, you know, it was very apparent straight away that there was either some cognitive impairment, learning disabilities. We weren't sure whether he was substance affected. We got him to do the UAM survey, and by talking to him about the questions, we got a wealth of information. His initial antibody test came up Hep C positive, so we did a Kefiad test. You know, it's worth saying at this point that one of the fundamental selling points of Hep C later is the extensive partnerships, and it was very apparent that this guy, you know, we were a little bit concerned about just letting him go. So we made a couple of phone calls. We had workers from shelter literally there within a few minutes to support that. We involved the Hep C Trust. So this guy really went away with a plan. He wouldn't have attended but for the incentive, and he got an incentive for the test, but he also got the UAM survey. And again, a robust, real plan and a quick diagnosis. He would have been lost to follow up with a dry blood spot or venous blood. We wouldn't have been able to keep him engaged. Then Mavis. Mavis was very difficult to engage, you know, long history on the Isle of Wight of trying to get Mavis to accept treatment, start treatment, exceptionally difficult to bleed. We finally, 9 months after she was prescribed, got her in front of us to start her on her meds. She was part of our validation verification for Nottingham Hospital. We did a Kefiad, it came back not detected. So, you know, again, thankfully, we were able to intervene and Mavis didn't go away with her meds on that day. Interestingly, her partner had previously been told he'd spontaneously cleared and he came up with a detectable viral load. So again, you know, this meant that somebody didn't have meds, that didn't need them, and the partner was engaged straight away into the treatment pathway. So this is just a bit about the patient feedback. One of the first people we tested with Cindy was somebody who completed 8 out of 12 weeks of their DAAs. Just at that point, they had to go back to hospital to get the meds. Really difficult place, you know, rural destination, couldn't get back. For 3 years, this girl thought that she had failed at her treatment. You know, really, you cannot get blood out. You know, even some of the best hepatology nurses in Wessex could not get this woman's blood. She fought for 3 years that she failed her treatment. She was one of the first people we used Cindy on, and yeah, she'd cleared it. Thankfully, her 8 weeks of 12, she was one of the lucky ones. Her treatment had worked, and you know, we were just all really, we were in tears. You know, like having for 3 years, this woman thought that she failed. You know, you can't underestimate that. We utilise Care Opinion, who some of you may know, for feedback on our Wessex clinical van and across the addictions provider alliance. You know, this guy, service is incredible. I haven't been tested in years because I don't have veins. It's so much hassle. The fact you came to the house and used your machine without needing to take bloods is one thing, but to tell me I don't have Hep C on the same day is out of this world. You know, I've been unable to get my SVR done. You've come to my house, like into my local area. Honestly, you know, it gives me goosebumps because we're all in this to support our patients, and these machines, I've got incoming cat, just to warn you. You know, are just incredible. So yeah, we've got a wealth of experience and knowledge now. I really don't want to give them back at the end of elimination. So you'll probably have to hunt me down. That's my disclaimer. They've transformed the landscape, seriously, and I will leave it there because I'm probably over time. Thank you.
Fantastic. Oh, feedback there. That seems to have gone. Great. Okay, fantastic. Thank you, Louise. Okay, so what I'm going to do, just because of the time, is I'm going to move on to Claire Edmondson. So Claire Edmondson is a senior scientist who has been working at the UK Health Security Agency, primarily on the unlinked anonymous survey of people who inject drugs for the last 6 years. She's really passionate about improving health and equity of care for people who inject drugs, and she's especially interested in the impact of emerging drug trends and bloodborne virus transmission. So Claire is going to talk to us about the Unlinked Anonymous Monitoring Survey of People Who Inject Drugs, aka the UAM survey. Claire, over to you.
Great, thanks, Deanne. I'm so glad that you said the full name of the UAM, so I don't have to, so thanks for that. So yeah, there's a reason why we call it the UAM survey, just because it's a mouthful otherwise. So without further ado, I'll get going. Thanks for that lovely introduction. So what is the UAM survey? Well, it's something we're really proud of. It's the longest running survey among people who inject drugs in the world and has been running for over 30 years. And that's due to our work with drug and alcohol services. You know, it's our data and it's your data, so we're really proud of that, and it's something you guys should be proud of too. It's an annual survey which recruits around 2,000 to 3,000 participants each year, and we recruit people who've ever injected a psychoactive drug. And people who inject drugs are recruited through drug and alcohol services across England, Wales and Northern Ireland, and we aim to get a nationally reflective sample. So you can see on the right of that slide, hopefully you can see my slides okay. Sorry, I should have checked. Yeah, all good. Great. Okay, you can see a map with little dots on it, and each of those dots reflects a site. The colour is how many samples were received in 2019, but just ignoring that, you can see that we're kind of all over England, Wales and Northern Ireland there. And we're always aiming to sort of fill in the blank spots. So if you're interested, please do contact me. So participating sites recruit people who inject drugs through different services, so be that NSP, alongside bloodborne virus testing, or through outreach, through the vans, etc. So the UAM aims to provide key insights into bloodborne viruses and risk and protected behaviours among this population, and the information that we gather is essential to improving services available to people who inject drugs. So why participate? So what's in it for your clients? Now, Louise covered this a little bit earlier, but if you run, well, clients taking part in the UAM will get a Love to Shop voucher. At the minute, that is £4 outside of London and £5 in London, but we're working on that to try and increase it, but watch this space. And that voucher can be used to help engage individuals who are reluctant to test. So if you wanted to run the UAM alongside a diagnostic test, it can help with engagement. Also, involvement in the UAM can empower clients because their participation provides data which is used to improve services for them. What's in it for your service? So we provide you a centre report if you send us 30 eligible samples within a calendar year. And what this centre report is essentially a really colourful and interesting display of all of your data from the questionnaires submitted to us, as well as the DBS sample BBV data, and it helps you further understand the population that you care for. This report can be used to evidence calls to commissioners for extra funding or initiatives. So if you look at the population you look after and you note, say you're in Telford, and you note that sharing in Telford is higher than that's seen nationally, sharing of injecting equipment, then what you can do is go to your commissioners and say, well, look at our UAM data, sharing's really high here, compared to, this is the UAM national data, compared to that, can we have some extra funding to run these initiatives to help engagement in NSP? The other thing that we can do for you is provide ad hoc analyses of your data. So if you have a specific question you'd like to answer, we can help you answer that if we have the data and a big enough sample size to be able to do so. So one of our sites in Bristol was really interested in naloxone availability and carriage in their area, and wanted us to help them characterise individuals that don't carry naloxone so that they can better target sort of naloxone promotion initiatives to that group. So we did that for them. So the UAM data isn't just used locally, it's also used nationally, as I say, to help improve services. And these are just some of the things that the UAM data goes into. So the UAM is the only data source capturing bloodborne virus status of those unwilling to test. So because we don't provide a diagnostic test to the individual, we don't give them their result back, we can engage individuals that maybe don't want to have a test to find out what their result is. And that helps us to understand the true prevalence of Hep C among people who inject drugs. We can characterise the population unwilling to test and help to adapt services to try and better engage those in diagnostic testing. The other thing is that the UAM provides longitudinal data for underlying levels of risk and service utilisation, and this helps us to understand why outbreaks occur. So there's been a recent outbreak in Northern Ireland of Hep C and HIV, and we worked alongside our Northern Irish colleagues to help characterise the population affected by this outbreak. And what we found was that there was increases in reported cocaine injection in the population affected by the outbreak. So that helped us, well, that helped our Northern Ireland colleagues deal with the outbreak, really. The other thing that our data does is it goes into a lot of national models for the overall Hep C prevalence, and also into estimates for the number of people who inject drugs. It helped inform the Dame Carol Black review and helps us monitor progress towards Hep C and HIV elimination. It's also fed into a lot of guidance, so as you can see, it is used quite widely. We also publish our data, so very exciting. On the 8th of February, we've got Shooting Up, our big infections in people who inject drugs sort of publication. And so this is a report, it's some data tables, but also within the package there's a slide set which can be used to present to your teams, and an infographic to display within waiting rooms and things like that, and that's essentially a one-stop shop for all data to do with infections and injecting related harms among people who inject drugs. We also publish our national results in a set of data tables each July for World Hepatitis Day. And on the left of this slide, embedded within those documents, are links to the website. So hopefully Dan will share these slides so that you can access these reports as and when you want to. So just to talk through the methodology. So as I mentioned, participants to the UAM survey are recruited through Drug and Alcohol Services. They complete a short questionnaire and provide a dry blood spot sample. So here I've just presented some of the wealth of data that we collect in the UAM. I'm not going to talk through all of these in great detail just because of time, but I wanted to give you a flavour of the data that we collect. So we ask questions on the types of drugs that we use, so we can monitor drug trends. We also ask about sharing and reuse of injecting equipment, as well as the site of injection. And so the pictorial on the right shows that over 1 in 3 reported last month groin injection. So this injection site was commonly reported not only among older cohorts or longer term injectors, but also quite worryingly among recent initiates to injecting and younger groups too. So it's not just that vein health has deteriorated over time and people were injecting into the groin. It is something that people are going and starting earlier on in their injecting careers. We also ask about experience of skin and soft tissue infections and number of injection attempts to help us understand vein health and adequate NSP provision. And here's some more of the questionnaire data. So asking questions around homelessness and imprisonment, sexual risk and engagement in transactional sex, and engagement in harm reduction, so Hep B vaccination uptake and uptake of diagnostic test. So the really interesting thing about that question is for Hep C, we ask about uptake of a diagnostic test and what the result was. So we can use that data alongside our laboratory testing data on the DBS sample to determine awareness of infection and sort of understand the proportion diagnosed versus those undiagnosed. So what tests do we do on the DBS sample that you submit? So we test for HIV and HTLV, which is human T lymphotropic virus. We also test for markers of current and ever infection with Hep B and Hep C. And through testing for Hep C RNA, which is a marker of current Hep C infection, we can monitor the number of new infections, assess the impact of direct-acting antivirals, monitor the characteristics of those with a current or recent Hep C infection. And as mentioned earlier, the UAM survey is anonymous, so individuals don't get their results back. So a lot of our sites tend to run the UAM alongside diagnostic testing, just because then the individual can have a diagnostic test if they want to, but also it helps increase numbers and engagement in diagnostic testing. So given the focus is on Hep C, I've included more detail on the data that we have for Hep C prevalence. So as I just mentioned, we test DBS samples we received for different virological markers to determine whether chronic or cleared Hep C infection has occurred and therefore determine Hep C prevalence, which is presented in the graph here. So each column in this graph is a survey year, with the red bars being, I'll point here, I don't know if you can see, here we go, with the red bars being chronic Hep C infection, so RNA and antibody positive, blue being past or cleared Hep C infection, and green being those that have never been infected with Hep C. So looking at the red and blue bars as a whole, this represents the proportion of people who've ever had a Hep C infection. So this is antibody positive overall. And this proportion has increased over the period of 2011 to 2020, with 60% being antibody positive in 2020 here. Then focusing on the red bars alone, you can see that chronic Hep C infection among people who inject drugs participating in the UAM initially increased from 26% in 2011 to a high of around 33% in 2016, and then prevalence declines to 20% in 2020, which is a statistically significant decrease from the levels seen in 2016 and 2018. So conversely, when you look at the blue bars, the proportion of people who inject drugs with cleared Hep C infection has increased from 19% to 44% in 2020. This increase in cleared Hep C infection, taken alongside the fall in chronic prevalence, suggests the fall in chronic prevalence is more likely to be the impact of the scale-up of Hep C treatment rather than improved harm reduction, as the number of people exposed is increasing here, this blue bar, and the number of people currently infected is declining. So here I've put in the second and last figure in this presentation, and this figure presents self-reported uptake of a diagnostic Hep C test over time. So from 2011 to 2020 again, with each column reflecting a different survey year, and the blue bars are those who've tested recently, so within the last 2 years, and the green bars are those who've ever tested, so they've had a test but not in the past 2 years. And as you can see, the proportion of people who inject drugs who've reported ever being tested for Hep C has remained relatively stable over the last decade, so the blue and green bars together. And in 2020, 48% reported recently testing and 37% reported a non-recent test. However, as 15%, so this blank space here, of those surveyed had never had a diagnostic Hep C test, and 37% reported not testing in the current or previous year, there's still work to be done to better engage people who inject drugs and promote regular uptake of diagnostic testing, especially as in 2020, of those with a chronic Hep C infection, only 35 were actually aware of this infection, 35%, sorry. So how do you sign up to support the UAM? So let me or my team know that you're interested in supporting the UAM. Our contact details are at the end of this slide set, or I think this is going on Twitter as well, so you can tweet, put a comment in the tweet. You can tell I'm not into Twitter, so sorry if that was completely tragic and I said that's completely wrong. We provide in-person or virtual UAM centre training to get you kind of on board and understand how to actually do the UAM at your site. We then ask you to identify a survey lead to lead the survey, and they're our main point of contact. Ensure that only eligible people take part and they keep an eye on stock, etc. And then we send out everything you need to take part, so all of the questionnaires, DVS, testing materials, etc. And then you start sampling. Thanks so much for your attention, and any questions?
Hi, thanks, Claire. Sorry, there's feedback again. So we've posted the email address in the chat for you, so please do make contact if you are interested. The other thing I would say is that we can always arrange for you to meet Claire and have a discussion around it as well, so you can contact the Hep C later team as well. I think the only question that I've seen in the chat so far was from Mark Gillian-Powell, and Sarah Croxford has luckily stepped in and answered it for you, Claire. So unless any more come up, what we will do then is most likely move on. So next we're going to do hopefully a bit of technological wizardry, and we're going to send you into breakout rooms, and this is the opportunity to essentially meet people and have a little discussion. So we're going to send you into rooms and we're going to ask you to discuss what types of tests you're using, what the strengths of those tests are, but also what strategies you can recommend for increased testing and retesting. So it's really an opportunity to learn from each other, especially in these times. So I will put that in the chat. Another warning as well is when your time is up in the breakout room, you'll automatically be pulled back into the sort of main arena of the webinar. If you press leave, you'll leave the entire webinar, so just be warned. So we will see you in about 15 minutes, and hopefully we'll just start disappearing very shortly. Hi everyone. So I think
we have to re-admit everyone, so I'll just keep doing that.
Yeah, everybody's joining us now. We're taking a little bit abruptly back into the webinar. So I'm really conscious that we've got very limited time left on our webinar today. So I'm going to close the webinar. But I would say please do reach out to us if you have any more questions, or if you want to discuss any more sort of barriers to testing and treatment. I would like to say an absolutely huge thank you to all our presenters today, and a huge thank you to everyone who attended, and to all of you as well for your sort of past, present and future work that you'll do to support Hep C elimination, and your efforts really are vital in this. We'll be sending some feedback forms as well, so please do fill them in, and it will give us an idea of what you want for future webinars. We have another one coming up in March, so hopefully we will see you then, and thank you very much, and do take care of yourselves.
Thanks, Deanne.
Thank you.
Thank you. Bye.
Thank you.
Bye.